My name is Blaes. I'm an oncologist at the University of Minnesota and the Masonic Cancer Center, and I was asked to talk about clinical features associated with cardiac toxicity during cancer treatment. There have been a number of studies over time looking at high-risk populations, like individuals who've had anthracyclines, have had radiation. This is exacerbated by being treated when either young or at an advancing age. And I think it's an exciting time in that there's several different risk prediction models that have been used to try to predict, particularly in childhood cancer survivors, breast cancer survivors, and in some of our stem cell transplant survivors, what actually that risk is. I think a lot of work still needs to be done. How do we incorporate other clinical features such as hypertension and tobacco use, other cardiac risk factors into actual clinical practice, as well as in some groups where we still have a lot to learn and don't have a lot of risk prediction models. I'm here today with Dr. Daniela Cardinale, and I hope you'll introduce yourself and talk a little bit about how do we incorporate biomarkers into those risk predictions as well.
Yeah, I'm Daniela Cardinale, and from Milan, Italy. I am a cardiologist, and I work at the Cardio-oncology unit of the European Institute of Oncology. And our approach to minimize cardiotoxicity is, as you said, to use biomarkers. The standard monitor, the current monitor of the cardiac function doesn't allow to identify early cardiotoxicity. So we thought to introduce the use of biomarkers, because today we have the possibility to identify cardiotoxicity very, very long before ejection fraction drop, and very long before the occurrence of heart failure symptoms, for example. We use troponin BNP at each cycle of anthracyclines containing chemotherapy, and this is an approach. It works very well at our institution, but also we introduced this approach in other 21 centers in Italy, and it works. This approach is reproducible also in other clinical realities. If biomarkers increase, you have the possibility to identify in this way high-risk patients, and we start promptly with the cardioprotective therapy. In this way, we prevent the development of a drop and in ejection fraction.
Are you routinely doing that amongst all patients or amongst those who are clinically at high risk based on some of those other features?
This is standard risk patient. For patient with pre-existing cardiology, cardiac disease, we admitted patients. We try to optimize therapy. We share obviously all information with the patient, with the family and our oncology colleagues, and we monitor biomarkers, both troponin BNP and frequently also cardiac function. And in this way, his approach resulted to be safe and allows to treat also patients at a high risk for cardiotoxicity as well.